Very good afternoon, esteemed delegates to this wonderful academic session. And at the PD Hinduja Khar, we are always very keen to pursue our academic endeavors and to keep educating all the medical fraternities. So with that today, with my passion on minimal access surgery, I thought stress urinary incontinence would be a very good topic to discuss, because as I said, we're going to soon start and initiate a SUI clinic in order to handle this chronic ailment in women, which we've been facing so long as consultants. These are some of the hospitals that I visit, but my major presence is out here every single afternoon. I visit Jaslok and I visit HN Reliance twice or thrice in the week in the mornings, more for minimal access. I'm honestly phasing out of obstetrics slowly. So let us discuss what is incontinence. So incontinence is an involuntary leakage of urine, and very commonly it could be of two types. So there is stress urinary incontinence, where a woman says that I leak urine on coughing, sneezing and laughing. And the second type is the urge, wherein there's an urgency to pass urine. The woman says, oh, when I get to the house, even before I open my door, I want to run to the loo because I feel I'm going to pee in my pants. Or when I go to the loo, I feel even before I open my pants, I may pee there. So that's the kind of urge incontinence. But today we're going to discuss more about stress incontinence. Urge incontinence usually is associated with diabetes or a cystocele, where the bladder is not evacuating properly, or there could be chronic infections or chronic cystitis. So we need to look into those. Why does stress incontinence happen? Let us understand that the pelvic diaphragm or the pelvic floor has three particular openings. One is the urethra, the vagina and the rectum. So with vaginal birth, what happens is when there is a strain on the pelvic muscles, naturally the diaphragm gets lax. So the urethra, which is an abdominal organ, becomes a pelvic organ, and that is where the force or the kind of continence that a patient should bear, or the kind of angulation that the urethra should have, is not there. So the urethral pressure usually should be more than the bladder pressure to keep a woman continent. So when a young girl coughs, sneezes or laughs, the urethral angle kinks and does not allow the urine to flow out, because the urethral pressure is more than the bladder pressure. In incontinence, what happens is this angle gets straightened out. So each time a woman even coughs, sneezes or laughs with a semi-full bladder, she leaks. And why could this happen? It could happen because of repetitive straining of the pelvic muscles. So it could be because of picking up a lot of weight, or childbirth, or pelvic muscle tone loss, which could happen with obesity, estrogen deficiency, menopause, and certain congenital anomalies or congenital conditions, wherein in certain communities we see the Ehlers-Danlos syndrome, where even in nulliparous patients there is all a laxity of the pelvic ligaments, and these are the patients who usually complain of leakage of urine on coughing, sneezing and laughing. So our selection criteria are very rigid when we know that a patient does not have any infection, that her sugars are normal, and she leaks urine on coughing, sneezing and laughing. So these are the patients we start to identify to see how we could make their lives better. So what are the treatment options? Before we suggest any sort of radical kind of therapies, we think we should always try conservative measures. So there is self-management with the help of Kegel's exercises, catheterization more in patients who have bladder laxity but not really in incontinence, and surgery, of course, to trying to lift the mid-urethra. There are also certain treatments like injection of Botox or bulking agents, but these are recurrently used and not so promising, because we've seen over the last 6 or 7 years with the advent of Botox that they tried to use these therapies, but they have not really picked up so well. How do you manage yourself is by adult diapers or pads, avoid too much of physical activity, reduce fluid intake, try to lose weight, lifestyle modulation, try to control your sugars, pelvic muscle or pelvic floor exercises, which is the Kegel's exercise. Now, how do I explain a Kegel's exercise to a patient is, imagine that you are at a bus stop where there is no proper toilet and you have the urge to pass the motion. What will you do? You will try to pull up your muscles in order to prevent the embarrassment of a loose motion. So when you do that, you're actually contracting the entire pelvic musculature. And if you do this in 3 sessions, 30, 30 and 30 for 3 months, especially in premenopausal patients or in between 2 children, in between 2 sessions of childbearing, these women can benefit with the Kegels exercises in the very early stages of SUI. So it can happen, and that's what we say, you squeeze while you sneeze. So when you do that, you can try to see that you can make your pelvic muscles exercised and stronger. And accordingly, we score the patient's relief. So when do we advise surgical treatment? Surgery is needed when conservative therapy fails. She says, Doc, I have tried. I've had 2 vaginal births. I've had very strained labors. I tried over the years. I tried my Kegels, but now with the approach of menopause, I'm seeing that I'm staining very often. I'm getting socially embarrassed, so I need to do something about it. So what is the goal? The goal is to restore the urethra and the bladder to its normal position in the pelvis.